Hi, everyone. Thank you for joining us today. My name is Alicia Cooper. I'm the Director of Partnerships and Development at Fertility Friends Foundation. We're a registered Canadian charity that offers grants to cover expenses associated with assisted reproduction, such as IVF, egg and sperm donation, and surrogacy. We're also very passionate about providing education and resources to families in need to support them along their journey. We want to provide a path forward to parenthood by reducing the financial and psychological difficulties that come with the infertility journey. Welcome to the webinar series. We aim to provide educational content and resources through this platform and are very happy to have Andrea with us today. It's a pleasure to introduce you, Andrea Djolovic, a certified genetic counselor and the founder of Genomicare, who we are a proud partner of. Andrea is also joining us for night one, our largest industry and fundraising event happening on Thursday, April 16th in Toronto. She'll be joining us as an expert in our exclusive patient-only experience as part of the event, the Fertility Insight Lounge. We invite you to join us, please, for night one. Tickets are available at fertilityfriendsfoundation.com under the events tab. You can go there for more information. We also want to mention that our grant application platform opens for the month of April. And lastly, next week, we will actually be announcing a new grant to support patients with their PGTM needs. And now it's a pleasure to hand the floor over to you, Andrea. Thank you so much, Andrea.
Thank you, Alicia. Thanks for introducing me. And I think that's really exciting news about the PGTM grant, actually. So I'll talk a little bit about the PGTM process, but I won't go into too much detail today, but a really, really exciting opportunity for families. Okay, let me share my screen. Okay, can you see my screen okay? Thumbs up, perfect. My name is Andrea Djolovic. I am a certified genetic counselor, and I founded a genetics clinic here in Ontario, basically to support families who are accessing fertility care and have questions about their family history or questions about their medical history, and just wanted more information about genetic testing that is available to them. So I am going to go over some of the genetic testing options that are available to everyone in Ontario, in Canada, in the world, I should say. Genetic tests that are available to everyone, but then specifically, I'll go into genetic tests that are available to specific people, maybe based on their ancestry, maybe based on their family history, maybe based on their personal history, and we'll take it from there. This is my email address. So if you have any questions after this call that come up, please don't hesitate to send me an email directly, or you can give our clinic a call and we may be able to schedule you a call with our genetic counseling team. So outline for today, really I want to talk to you about the importance of reviewing your medical and family history with someone in genetics. What we do here is we screen for medical history or family history concerns that could impact your health or even your fertility journey. And I'll go into more details about this. We'll talk a little bit about the review of pre-implantation genetic testing for aneuploidy, so PGTA. We'll go over the benefits, the limitations, and the types of results that you can expect. We'll talk about genetic testing options in you, the parents. So this is again goes back to the specific medical family history, ethnicity, expanded carrier screening. And one thing I do just want you to know is that having a genetic counselor on your team in your fertility journey is really important. But I do want you to know that genetic counseling doesn't equal genetic testing. I have heard families decide not to meet with a genetic counselor just because they're like, well, I don't want the test. That's okay. You don't need to want genetic testing. Sometimes it's nice to just review your history, review your options, and just kind of get up-to-date information. So I just my little reminder that I say to everyone, genetic counseling doesn't equal genetic testing. Regarding personal and family history, so our team of genetic counselors, what we do is very early on in our call with you, we ask you a little bit about what's brought you to your fertility clinic, as well as kind of any health concerns that you've presented with, anything that you're being followed for long term, and then we move that beyond you and your partner, and we go into your family history. We also do review donor sperm and donor egg profiles as well, and we go over that if that is the way that you are conceiving. Now, some of the important questions we ask are history of cancer and heart disease, pregnancy loss, if there's anybody in your family that's presented with developmental delay, intellectual disability, if there is any shared ancestry between you and your partner, referred to as consanguinity, and then specific ancestries, we ask everyone, where is your family from? What's your ancestry? And some of the ones that are eligible, some of the ancestries that are eligible for additional genetic testing are people who have Ashkenazi Jewish ancestry. There's a very specific region in Quebec called Saguenay-Lac-Saint-Jean where there are some genetic tests available, and others. There are others. So that's why having a consult with your genetic counselor team is just helpful, just to cross your T's and dot your I's. Now, PGTM, pre-implantation genetic testing for M stands for monogenic conditions. This can be considered in very specific cases. When we have a known genetic syndrome or condition in a family, whether it's in you personally or it's somewhere in your family, and there is a genetic test result that confirms the presentation that the person has, people can do a genetic test called PGTM. This is one I won't go into too much detail about today, but if you have any specific questions about your personal history or your ancestry or anything that you're like, PGTM might sound like something I need, please send me an email and we can chat about it further. But let's go into PGTA, pre-implantation genetic testing for aneuploidy. This is a test that is available to everyone that is doing IVF. So to break down the acronym, P stands for pre-implantation, meaning that the embryo is tested before it is transferred and implanted back into the uterus. The term G is basically focusing on the high-level genetics of the embryo, specifically looking at the DNA and the chromosomes in the embryo. The term T is for testing, but a little bit more on this later. And then the final term, sort of the big term, is A for aneuploidy. This is the scientific term for a chromosome imbalance. So soon as an embryo is predicted to have too much genetic material or not enough genetic material, it is considered something called aneuploid. But let me go back one step in genetics. So if, for example, you were to take a pinch of skin and look at the skin cells under a microscope, what you would see at the very center of our skin cells is these X-looking structures called chromosomes. And all one chromosome is really, really tightly packed DNA. And DNA is what carries our genes. So our hair color, our eye color, how tall we are, everything about us is coded on our genes. Even actually, there are genes that protect us from cancer, like the BRCA1 and BRCA2 that most people are familiar with. These are all genes that we've inherited from our families. They're carried on our DNA. Now, if we were to take our DNA and we were to squish the DNA strand into the smallest container, that container is a chromosome. This is actually what chromosomes look like under a microscope, okay? They look like these wormy, beady looking things, black and white pattern lines. And we as humans have 46 chromosomes total that come in 23 pairs. So number one is our biggest pair here, and 22 is our smallest pair. And then we have our sex chromosomes, XY. XY is typically male, and then pretend this Y chromosome wasn't there and there was just two X's side by side. That's typically female. Now, when we do PGTA, what we're looking for are embryos that are predicted to have this complete set. One of each copy of the chromosomes would have been inherited from the sperm, and one of each copy of the chromosomes would be inherited from the egg. I just wanted to flag here, though, I know I show sex chromosomes on the slide, the X and the Y, but here in Canada, the sex of the sex of the embryo isn't typically reported. Okay, there are absolutely exceptions to this, where there's a family history or medical history, but typically PGTA does not report on the sex of the embryo. And then a little bit of an overview of IVF and where PGT fits first before I get into more details. So the routine IVF cycle, starting with hormone therapy and egg retrieval and sperm collection, moving on to fertilization of all of the mature eggs. And from there, your fertility clinic, what they'll do is they'll watch as your fertilized eggs grow and develop till they're about day 5 or 6, sometimes day 7. And it's at this stage where they can then do genetic screening on the embryos, genetic testing on the embryos. I put some flags up here because most of the time in Canada, The PGTA testing, the biopsy testing, is actually sent to the States, but there are absolutely more and more clinics in Canada where testing is being done in-house in the actual fertility clinic. But regardless, your entire embryo stays in Canada. So just the biopsy is what's traveling for the test. And we wait a few weeks for the results to come back. While we're waiting, your embryos are frozen, called cryopreserved. And we're basically waiting for the results to come back. And then when they're back, we can decide from the results which embryo to transfer first, which embryo to transfer second, and so on. Okay. A little bit of a embryology background. So when your embryos reach day 5 or day 6 of embryo development, this is in IVF, your embryos are called a blastocyst. A blastocyst is made up of two cell lines. So we have this cluster of cells here in the middle. This is a cluster called the inner cell mass. And then surrounding the outside of the embryo is this layer called the trophectoderm. And the trophectoderm is what develops into the placenta and tissues that support the pregnancy, while the inner cell mass, the cluster in the center, is what develops into a baby in an ongoing pregnancy. When your embryo reaches day 5 or 6 of development, the blastocyst stage, it is about 100 to 200 cells big, okay? And when your embryology team is taking a biopsy of this embryo, they're taking a really, really small biopsy. They're taking something like 5 to 10 cells of the outer layer, that trophectoderm layer, the part that becomes the placenta. And a lot of people here ask us like, okay, is there harm to my embryo when we add a biopsy? No, I shouldn't say most, all embryology teams are pretty consistent in telling us that the risk is negligible. It's really low risk. They are very cautious when they visualize the embryo. They're very cautious to even say, we've seen sometimes they're like, this embryo is just looking a little less strong than the other embryos in this cycle. Maybe we don't biopsy this one embryo because we're worried about it surviving a biopsy. But otherwise, the risk to a healthy embryo is truly negligible for biopsy. Once your embryo has been biopsied, the results typically, again, every clinic is a little bit different, but results typically take 3 to 4 weeks to come back. And that's when you would meet with your team to review these results. Now, there are different types of results that can come from PGTA testing. High level, there are three that I want you to be aware of. The first is something called euploid. This means that the embryo biopsy is predicted to have the correct number of chromosomes in for this embryo. This would be the first embryo you would consider for transfer, and it would have the highest chance of ongoing pregnancy, and it would have the highest chance of implantation. So this is the embryo that we are looking for. I'll skip I'll skip mosaic for right now. The other sort of on the other end of the spectrum is the term called aneuploidy, which we've already reviewed, meaning that there is predicted to be an incorrect number of chromosomes, too much genetic material or not enough genetic material. When this happens in an embryo, when an embryo is predicted to have too much or not enough genetic material, we expect that that embryo won't implant or won't lead to an ongoing pregnancy. And so we put these embryos at the very bottom of the list for transfer. Now, every lab is different and every fertility clinic makes different decisions on the mosaicism call of an embryo. But let me tell you what a mosaic call is, and then if you have any questions, we can go over it in more detail. But some labs report an embryo as mosaic. So what that means is they took a biopsy, they sent the biopsy for genetic testing, and in that same biopsy, they found DNA that was either a little bit extra or a little bit less than they would expect, but not in the full amount. And I have these graphs at the bottom of the screen that kind of show. So just drawing your attention to the mosaic graph. Here you see a little red arrow that points to a tiny little decrease here right around the number 13. And then as well, there's a little bit of a bigger decrease, a dip in the graph, right around chromosome number 21. So this embryo biopsy, this example here, is just saying that there is less chromosome 13 and less chromosome 21 in the biopsy, but not in the full amount that the lab would call it aneuploid. So that means we can assume that there are some good cells in this biopsy as well as some aneuploid cells. So the combination of good cells, combination of aneuploid cells together, call that embryo as mosaic. And just in another way to show you the results, like I said, the one that we're looking for is the euploid, also referred to as a normal embryo result. It when you have euploid embryos, you really work with your embryology team and your fertility clinic just in regards to transfer next steps. There's very little additional options when once a euploid embryo is transferred beyond routine prenatal screening wherever you are. Um, the results that get more complicated that a lot of people bring to our team are embryos that are, like I said, mosaic, low level or high level. Now, I'm going to be vague here because different labs report low level and high level. Different labs have different cutoffs. So some labs have a 30 to 50% cutoff for low level mosaic. Other labs have a slightly different range, like something like 20 to 40% or something like that. I can't remember off the top of my head, but different labs have different reporting levels and report low level, meaning there's a low number of aneuploidy in the cells. So more good DNA, good chromosomes are in this biopsy, but there is absolutely some aneuploid detected versus high level, meaning there's a higher level of aneuploidy predicted in this biopsy, but there are still some good looking cells. Things I want you to know is that mosaicism is independent of maternal and paternal age. We quote about 10% of all results are coming back mosaic these days. But we have seen that the complexity of a mosaic result does increase with maternal age and paternal age as well. And then just for you to be aware, with PGTA, the results can get a little bit confusing within the aneuploidy category. So this is the category where I said, let's put it at the bottom of the list. Let's not consider them for transfer. Recently, there have been some studies that have transferred aneuploid embryos. So the embryos that to date we've been saying, let's put them at the bottom of the list. The two that are being flagged more recently are the segmental aneuploids and embryos referred to as sometimes complex, but more often chaotic. It just means that they found a little bit of extra genetic material on a part of a chromosome when they refer to it as segmental. People have been exploring the option of transferring these, and chaotic as well. Chaotic aneuploid meaning that six or more chromosomes were found. So they found multiple whole chromosomes missing or extra in the same biopsy, and the lab have termed that as chaotic. And some clinics and some families are exploring these as an option for transfer as well. I should note that I just flagged these two that are giving us a little bit more of a gray zone result. There are absolutely whole chromosome aneuploids where like a whole piece of chromosome 1, for example, is missing, or a whole extra copy of chromosome 15 is found. Those we're saying very, very low implantation rate, very, very low ongoing pregnancy rate, and we would not recommend those for transfer. I'm just flagging these two that today in 2026, we're just talking about a little bit more often or advising families not to discard or donate. And then the final result is something called a no result. It occurs in about 2 to 5% of all embryos that undergo PGTA. So what it means is they took a biopsy, they sent the biopsy off for genetic testing, and they were not able to make a call on the result of the biopsy. It can happen for a bunch of different reasons. Nobody can tell you exactly why it happened for your embryo, but there are a bunch of different steps where something could just maybe not work as well. Maybe the embryo itself is not as good quality and it was really difficult to visualize it at biopsy. That can happen. The biopsy could have been perfect, but just not enough DNA was in the cells of the biopsy. Um, Everything could have worked, but the DNA could have degraded being prior to being genetically tested, or kind of once it's at the lab in for genetic testing. Sometimes there's a step called amplification. Just picture it like photocopying. It's a really small sample of DNA that they take, that they extract from your cells. They have to photocopy it. They have to amplify it to make it bigger so that they can actually analyze it. Sometimes this step fails, and then everything could have worked perfectly, but that graph I showed you on the last slide, instead of having a really nice clean line for results, the line can be really messy, kind of just jumps up and down, and it's an unclear profile for that biopsy. And often it's just like that result is not predictive of your embryo. It's just a technical artifact usually. Um, Typically, it's an embryo that families can consider for transfer, or it's an embryo that families can consider for rebiopsy. And just to kind of put all of this information into one slide, sort of a result guide. Euploid is the embryo we're looking for, highest priority for transfer. If there are multiple euploid embryos from a cycle, we often put that back to the embryology team and they consider the embryo grading. It's what is done on day 5 or 6 of your embryo biopsy, where the embryology team grades your embryo as high, medium, or sometimes lower. And basically they use that grading to guide transfer of these euploid embryos. Mosaicism, like I said, can absolutely, actually, I don't think I said this. Mosaic embryos can absolutely be considered for transfer. Usually, a discussion with your team or a genetic counselor is really recommended. What we do for families who have mosaic embryos, we talk a little bit about pregnancy management or options that people can access, and families then go back and decide if they want to consider that embryo for transfer or not. So it's definitely most of the time can be considered for transfer, and then it's back to you to decide if it would be something you would consider. A no result embryo can be considered for transfer, can be rebiopsied. We just consider the age of, we consider aneuploidy, so the chance that it's an abnormal embryo based on the age of egg at the retrieval. And I'll talk about a little bit more about that. And then aneuploid. We don't typically recommend these for transfer, though, of course, like I said, there can be some exceptions. And there are some embryos we discuss a little bit further when they are flagged as aneuploid. I might take a break here and just see if anyone has any questions. Okay. Please feel free to ask questions or even just write them in the chat box and we can go over them together. Alicia, is that okay?
Yes, I was just about to say that. Yes, you're more than welcome to put your questions in the chat box and we can go through them that way. If you think of something, while Andrea's talking as well, you're more than welcome to pop it in there. And then when we get to questions, we can answer them.
Okay, so I've done a lot of talking about what
Wait,
PGTA
sorry,
can.
sorry, I do see a question here.
Oh, sure.
Sorry. Um, Question is, would you recommend transferring more than one mosaic embryo?
Ooh, that's a really good question. So there is literature that tells us the possible. There are some mosaic embryos that have actually very good outcomes. So a low-level mosaic, a low-level segmental mosaic, for example, the rate of implantation is about 50%, and the chance of an ongoing pregnancy is about 40%, which is very, very comparable to a euploid. So two mosaics that are kind of at the higher end of good outcomes. I would not recommend for transfer, like two at the same time. I would also very much delegate that question back to your REI. But typically, the only times I've seen multiple mosaics transferred at the same time are maybe ones that have higher level mosaicism, so more aneuploidy, more abnormal cells are detected in the biopsy, and there's a lot of chromosomes impacted. So maybe instead of just having one chromosome extra missing, it has like 2 or 3 chromosomes impacted, plus it's a high level mosaic. I have seen physicians consider doing multiple transfers because the chance of implantation for one is lower. Basically, they just don't want to transfer two embryos that both have really good possibilities of implanting and working really well, and then kind of put the both implant work, and then now you're carrying a multiple gestation pregnancy. So that's what they're trying to avoid because of course there's risk with multiple gestations to you and to the pregnancy. So long story short, I've seen it, but it's very much a case by case answer.
Thank you. Perfect.
Okay. Um, so now the pros and cons of PGTA. Really, we say that all couples, regardless of age, are at risk of producing these aneuploid, quote unquote, abnormal embryos, making PGTA an option for a majority of IVF families. Now, what I need you to know is this is a screening test, okay? So this isn't diagnostic, meaning that most labs quote an accuracy of 98%. So technically, they could call an embryo euploid, but it's actually aneuploid. This is rare. It happens like just over 1% of the time. And the inverse is true. They could call an embryo aneuploid abnormal, but it's actually good. Even more rare, happens less than 1% of the time. So it's just me saying this isn't a perfect test that is guaranteeing a perfectly healthy baby. All it is doing is helping you prioritize which embryo to transfer first, which embryo to transfer second, and so on through the results of your cycle with the goal to get you to pregnancy sooner. Okay. Now, it doesn't look for everything. So, for example, it doesn't look for things like autism spectrum disorder, cancer, family history of anything. So, this is where, if there's a family history of something or something that you're concerned about, this could be where PGTM is applicable. But absolutely talking to a genetic counselor or your REI more about what it is you're concerned about, it is a very good start. And then the cons of PGTA. So, what we know is that a euploid embryo, it doesn't always implant and lead to an ongoing pregnancy. Today, we're quoting anywhere from 40% to 65% chance of an ongoing pregnancy. Your clinic may have clinic specific numbers as well. So it can be very frustrating to do all of this work, get all the results back, transfer your euploid, and for it to still not implant or lead to ongoing pregnancy. Now, it is possible that after we do PGTA, there isn't a good embryo we recommend for transfer. So, what does that mean? It means that you've had maybe 3 embryos, 4 embryos from your cycle. They were all sent off for genetic testing, and maybe they all came back with chromosomal aneuploidy or maybe even mosaicism, and you're just uncomfortable with transferring a mosaic as like a family. This is something we always talk to families about before PGTA because there are there are factors that kind of increase your chances to have a good outcome, really, more embryos, younger ages, and things like that. But even people who are of younger age and have multiple embryos have had cycle outcomes that where we say there isn't an embryo we would recommend for transfer. So I always tell families like every cycle of IVF with PGTA is unique. I've seen 2 people have, one outcome where it we say there isn't anything we would transfer here, and they've gone back to the exact same clinic with the exact same doctor, that same lab, everything is the same. They're the same 2 people, and they've had a completely different cycle outcome. So it's just me saying that the PGTA results don't define you. Typically, and there's exceptions to everything, but typically PGTA results are just the results of one cycle. And then beyond that, everyone, regardless of how they are conceiving, has a 4 to 6% background risk of something, anything, being identified in a pregnancy, whether it's identified during birth, whether it's identified during pregnancy or after birth, things like congenital heart defects, maybe the way the brain's develop, maybe the way the hands or feet are developing. So everyone has that risk inside of IVF and PGTA and outside of IVF and PGTA. Okay, so there is a lot of data on ages and aneuploidy. Most of the data focuses on maternal age because we know that as women are born with their eggs, and as women age, their eggs age with them. There is some data as well to suggest that paternal age can absolutely play a role. Paternal age plays more of a role on single gene things, or smaller deletions and duplications, whereas the egg most of the time contributes the whole chromosome extra, whole chromosome missing. Somewhere in the realm of like 90% of whole chromosome aneuploidy can be assumed to be of maternal origin. And really, it's biology that's to blame here. When a sperm has too much genetic material or not enough, typically a sperm just don't do very well. They're not moving very well. They're actually maybe not even existing if they're missing too much genetic material or have too much, they just die. So again, another reason why most of the time whole chromosome aneuploidy is of maternal origin. Now, there are many studies that have graphed the rate of euploidy across aneuploidy and shown that as we age, the rate of aneuploidy does increase. So, wherever you fall into these age categories, just know that it's in the 36 to 40 range. We usually tell people after an IVF cycle to expect about a 1-to-1 ratio of euploid to aneuploid. So, good to maybe, again, deprioritize. So, if you have 4 embryos from a cycle, maybe 2 are going to be euploid and you can absolutely consider for transfer, and then 2 might be aneuploid. This graph is a little bit older too. The study's a little bit older. They graphed mosaicism in green here. I think a better number for mosaicism today is closer to 10%. So these are a little bit inflated, but just know that everyone kind of regardless of age has that 10% chance of mosaicism. Okay, let me review IVF attrition and timelines really quickly. So what we know is that every step of the way in IVF, we may see a little bit of a decrease in how many embryos or how many eggs we start with compared to we how many eggs we start with compared to how many embryos we end with. So just a rule of thumb, usually the number of eggs retrieved, about 80% of them are expected to be mature, okay? And then from there, we may see only 50 to 70% fertilize. And then from there, we expect 30 to 50% to continue to grow and develop to day 5 or 6. So then this is sort of where we add that age-related aneuploidy graph of considering if you're in the age of 36 to 40, 1-to-1 ratio. If you're older, maybe it's a little bit more aneuploidy and a little bit less euploidy. And then if you're younger, we expect a little bit more euploidy. We expect the inverse. So and then, like I said, 3 to 4 weeks after your biopsy, you would meet with, not with me, but with somebody on your team to review your PGTA results. I am going to shift gears now, and I'm going to talk about expanded carrier screening. It's a test that we recommend for all families that are doing, actually, all families preconception, not even just families doing IVF and PGTA, but basically anyone preconception. This test is recommended for. Before I shift gears, if anyone has any questions, please don't hesitate to ask. Otherwise, let me talk a little bit about this test. Now, this test is absolutely optional. Before you proceed with IVF and PGTA, before you proceed with IUI, even before you proceed with natural, if you're trying spontaneous conception. So, what is it? Expanded carrier screening is a genetic test which, with the goal to identify couples who are at risk of passing on serious genetic conditions to their children, to the next generation. It is performed on individuals who don't have any signs or symptoms of this particular genetic condition. So this is really important for you to know. Being a carrier for a lot of these conditions is what I call silent. You have no idea you're a carrier. And by the way, every single one of us on this call is a carrier for probably multiple genetic conditions. We just don't know what we carry again because, like I said, it's silent. We don't know what it is until we do a genetic test like this, or sometimes families find out about it because they've had a child, somebody in the family has had a child affected by the condition. So really the goal of carrier screening is to provide future parents with information that they can use to really guide pregnancy planning and fertility planning. Now, what actually is it? So like I said, it's a testing you to see what conditions do you carry. And the reason we test you is because when two people both carry the same thing, that's when there's a risk to the next generation. And that's the big flag. We all carry something. You and your partner we all carry, all humans carry something. The risk is only when two people both carry the same thing, the same condition, because then they have a risk of passing it on. And this little picture on the right does a good job of showing how, in this example, there's a carrier father, so he has one copy of a gene that's altered, which is the blue square, and he has one copy of the gene that's working totally normally, white square, and he's a carrier. He has no idea he's a carrier. He has no signs or symptoms of it. Same thing with carrier mother. Uh, Carrier, the blue square, carrier of a condition, white square, unaffected. Sorry, I shouldn't say unaffected. Normal gene, everything looks good. This mom also carrier. She has no idea she's a carrier because no signs and symptoms. But when this couple goes on to have a pregnancy, in any pregnancy, which copy of the gene they pass on is 50-50. So if they both pass on their blue square, the altered copy, to a child, this child now has no working copies. And as soon as a child has no working copies of a gene is when we see signs or symptoms of the condition. And along the left-hand side here, I just show some very common carrier conditions, so conditions that more people in the population carry than others. So cystic fibrosis, we see about 1 in 25 people carry this condition. Spinal muscular atrophy is another commonly occurring condition. It's about 1 in 35 to 1 in 50 people are carriers. So if you're that 1 in 50 and your partner is also that 1 in 50, you would have this scenario on the right of having the risk of having a child affected. So the risk is when two people are both carriers, it's about 1 in 4 or 25%. Now people are like, what am I going to do with this information? So I just want you to know that all of these conditions on the panel are pediatric onset, and some, if not most, I should say half, are associated with a shorter life expectancy. About a quarter of the conditions on the panel, so there's a lot of conditions on this panel, about a quarter of them are associated with limited or no treatment options. A quarter of the conditions are associated with the risk of intellectual disability. And then about a quarter of them are associated with when we know about it ahead of time with early intervention, families do absolutely really well. I know these don't add up to 100%, by the way. It's just the panel's really, really big. And so these are just big categories for you to consider. So, like I said, you've done this test. What can you do with this information? When two people are identified to be carriers of the same thing, we can absolutely consider preconception testing or planning. So, plan for additional testing in their IVF cycle is just a cryptic way for me to say PGTM. Absolutely, this is when PGTM is very applicable. Um, Families can consider donor gametes, so donor sperm or donor egg. Families here can also explore the option of adoption. Some families decide to continue on with pregnancy and they want to do testing in pregnancy to see if the pregnancy is affected and anticipate outcomes after birth and delivery. And some families just wait until after birth. Again, it really depends on the condition, I should say too, but some families wait for management and therapy and just decide to have access to a specialist care hospital. It should, if they know that they have a 1 in 4 chance, a 25% chance of having a child affected. And like I said, some have absolutely very well defined diet, lifestyle, medications, treatment options, and families just get that in line before the birth of a baby. Um, One thing I didn't mention is about 2 to 3% of all families are carriers for the same thing. Okay. So this is really much a test of crossing your T's, dotting your I's. Most of the time, when we test families, male partner, carrier for a couple things, female partner, carrier for a couple things, and they just carry two completely different things, and they cross their T's, they dot their I's, and they move on, and they just do whatever they were going to do. But we do see about 2 to 3% of the time families are carriers for the same thing, and that's when it can change sort of their next steps, their management. And again, PGTM, and it's very honestly really exciting that the Fertility Friends Foundation has this grant for PGTM because it is absolutely a test that families need sometimes. Our team does do expanded carrier screening. It's expensive. I've put the pricing as of, where are we? February 2026 online here. We aren't the ones actually doing the testing. We partner with a lab called Natera. So if you're interested, honestly, you don't even have to be like, I want this test. You can just be like, I want more information about this test. You can find us online and schedule an intro call with our genetic counseling team. There's no fee. It's just us telling you, hey, this is what the test is, and these are the pros and cons of the test, and then you can tell us if you're interested or not. But these are the prices, and the results take about 3 to 4 weeks. That is everything for me for genetic testing in IVF and fertility care. Does anyone have any questions?
Thank you so much. That was great and very informative, and I know I learned a lot. If anybody has questions, you can either unmute yourself and ask again, or you can put it in the chat and I'll read it out loud.
And if you want to chat family specific things or like personal history of things, just email. This is a confidential email that you can reach out to. I'll stop sharing.
Give a minute or two to let people think of think of any questions. I have a feeling most people's questions will be kind of personal and they might email you.
Yeah, absolutely. Elaine actually
Yeah.
made a question. How does genetic counseling work when families using donor gametes? Great question. So we often review the donor profiles and the donor gametes genetic testing results. If you've looked through donor gametes yourself, you'll see that every don I shouldn't say every donor. Most donor banks are testing their donors for pretty big expanded carrier screening panels, which is that test I talked at the end about. So sometimes we review what conditions the donor carries, and we review kind of with you if like that's a condition you're concerned about and you would want to test yourself for. And then if, for families that have decided, yes, I want to test myself for this condition because I'm really worried, this is a severe condition to me and I would want to know, we would then do a donor match. So we would compare the results of the intended parent, we compare the results of the donor, and usually we give a thumbs up, your likelihood of being a carrier for the same thing again is at 2 to 3%. But there have been times where we've said, you know what, let's not proceed with this donor because you have a higher risk of a genetic condition with this donor, and then families go on and pick another one. Our team, we actually recommend shortlisting 2 to 3 donors usually in the donor gamete process, and then our team reviews 2 to 3 donors with you alongside your genetic testing results.
Thank you. Any other questions from anyone? There's another one. For embryo donation, do you recommend donors are tested?
So when families are donating embryos to other families, is that what you mean? Yeah. Um, that's a good question. Um, I think different clinics have different policies on this. Again, I can't say recommend, but I would say that there is a publication. It came out in like April 2025, so it's pretty new, and it's a Canadian publication saying that there are definitely 10 genes across, we have 20,000 genes, so we have a lot of genes making us who we are. There are 10 to 12 genes that they say we should absolutely test for everyone preconception. So it's a Canadian policy statement, and they think everyone preconception should get this. The caveat is that they also put this in the article. We as Canada do not have the capacity or the funds or the like testing infrastructure to test everyone preconception. So they kind of just neatly recommend it and then go, but we don't actually have a solution for how to do this. And then they're working on it, but they've left it there. So
Yeah.
I would say that there's at a minimum 10 to 12 genes, whatever this article quotes, and I can't remember the exact number, but those would be recommended. A bigger panel is really then at the discretion of your fertility clinic or kind of you if that's what you're deciding to do. One day we'll have expanded carrier screening covered by the province, and this won't even be it won't even be an issue.
Or anything else you want to mention, Andrea, before we come to the end?
Honestly, our website is genomicare.ca. We have the opportunity for families to just reach. It's a 15-minute intro call. Families will book an appointment with us and be like, hey, I've had this happen in my family. I've had this happen in my IVF cycle. I've had whatever the scenario. And what do you think? And sometimes we're like, genetic counseling can't, doesn't sound like it would help you, but other times we're like, this is what we can offer. And we'll kind of mention to you what we can offer. And then it's up to you to decide if you want to proceed with that. So it's just us saying like there are and maybe not even Genomicare. There are so many genetic counselors across the country that can support you. So um that's it. If you have very specific questions, please like don't hesitate to ask. Okay. Thank you, Alicia. Thank you, Isabel.
Thank you, and we're honored to have you. Thank you.
Thanks. Okay. Have a good one. Bye.
You too.